Hello, we'll start this lecture with the third topic, electrolytes imbalance and osmolality disorders. We'll deal with six subtopics in this topic. Hypernatraemia is defined as the serum sodium concentration is below this reference range. The serum concentration of sodium is a ratio of sodium in millimoles to water in liters. This condition can arise because of the loss of sodium ions or the retention of water. Most patients who are having this condition are due to water retention. A condition is called the so-called SIAD. The SIAD is encountered in many conditions like infection, malignancy, etc. It results from the inappropriate secretion of AVP. Edema, it's a condition due to the accumulation of fluid in interstitial compartment. And you can see that the pitting edema, it's after depressing the skin fails to come back to its position and the pit is seen. It arises from a reduced effective circulating blood volume due to either heart failure or decreased concentration of albumin. The response to this, the body responded by a condition called secondary hyperaldosteronism, in which the aldosterone causes sodium and water to be retained, thus expanding the volume of the ECF. Patients with edema become hyponatremic despite sodium retention because AVP secretion is increased, resulting in additional water retention. If we want to summarize the hypernatremia, it is due to the fluid retention or sodium deficiency. The fluid retention can result from edematous or non-edematous condition. The edematous due to the high water intake due to the inappropriate IV saline, or low water due to the excretion as a result of many conditions, including nephrotic syndrome. The non-edematous due to the high water intake, this means increased water drinking, or low excretion rate due to other conditions like renal failure. While the contracting of the EC volume, which lead to sodium deficient, may be to the loss of the ECF through the gut, kidney, or skin, or the low intake of the sodium causing the sodium depletion. If you look to this tank, in case of this water tank will show the reduced ECF volume and how it affects the concentration of the sodium. In figure A, you can see the concentration of the ECF is reduced. The concentration of the sodium is reduced because it's highly diluted ECF, while in B it's a highly concentrated ECF. That's why the concentration of sodium increased, while the C showing the normal, and you can see the color of the ECF is like a shade between A and B figure. Actually, the hypernatremia, as we said before, is controlled by aldosterone and AVP secretion, and they are increased in their secretion due to when the blood volume is decreased and being sensed due to heart failure, or as we said before, or decreased albumin in the blood. This will cause sodium retention and water retention, leading to hypernatremia. This table is just for knowledge to see the clinical and biochemical feature of sodium depletion and SIAD. Another condition is called pseudohyponatraemia, false one. It's a false one. And this, as you know, hypernatremia is sometimes reported in patients with severe hypernatremia, severe hyperproteinemia, or hyperlipidinemia, high increase of protein or high increase of lipids. In such patients, the increased amount of protein and lipoprotein occupy more of the plasma volume than usual, and the water less. So sodium and other electrolytes are distributed only in the water fraction, and these patients have a normal sodium concentration. Although the test will show that they have less sodium concentration because the other volume of the blood is occupied by the high protein and the high lipid. However, many of the methods used in the analytical instrument measure the sodium concentration in the total plasma volume. Actually, they are not accounting for only the water fraction. That's why the concentration of sodium appears to be low, although it is not low. So it's not accurate. The low sodium result may thus be obtained in these conditions. Such a condition should be suspected only if there is different data between the degree of apparent hypernatraemia and the symptoms. So they must relate the symptoms with clinical report. So in this figure you can see that to the left, you have a normal condition, sodium concentration around the range. But if you if you measure the sodium concentration in the total serum, and if you measure the total in the far right, if you measure the sodium concentration, you see that is below normal, below the reference range, 108. So this indicates it might be a case of hypernatraemia, but actually it's not a case of hypernatraemia, it's a case of pseudohyponatraemia. Because in the middle, if you measure in the serum water only, in which sodium occupy the water fraction, you find that the range is again back to normal. So that's a pure case of pseudohyponatraemia. The hypernatraemia is another condition which is all the way opposite to the hypo. Just as hyponatraemia developed because of sodium loss and retention, so having developed from either water loss or sodium gain, the other way around. A high plasma osmolality may sometimes be encountered for reasons other than hypernatraemia. Causes include increased urea in renal diseases, hyperglycemia in diabetes mellitus, the presence of ethanol or some other ingested substance. Any difference between the measured osmolality and the calculated osmolality is called the osmolality gap. If this gap is large, this suggests the presence of a significant contributor to the measured osmolality, unaccounted for the calculated osmolality. In practice, almost it's due to the presence of ethanol in blood. If you look to this figure, you'll see that the main cause of hypernatremia is commonly associated with the contracted ECF, and less commonly with expanded compartments. So you can see in A, when the ECF is contracted and the volume of ICF are reduced, this will lead to hypernatremia, as well as you can see with more severe in the figure B. As we can see, the clinical feature, you can see that the skin turgor pressure is decreased. The sign is frequently unreliable in elderly, because it's normal, because they lose the elastic, they lost a lot of elastic fibers in their skin. But if the patient is young, this means there is a dehydration, severe and fluid loss from the ECF. This means that ECF is contracted, so the sodium concentration increased. So that's a case of hypernatremia. This all will summarize the contraction of ECF volume and how they relate, the clinical features, and how they relate to hypernatremia. So you can see decreased skin turgor, soft sunken eyeballs, dry mucous membranes, increased pulse, and other features. We'll talk now about the third subtopic. It's the hyperkalaemia. It is concerned with potassium disorder, because they are important balance between this. The balance of potassium is important to determine the resting potential, membrane potential of cells. Changing in plasma potassium means that the cells become excitable, such as nerve and muscle cells, and they may respond differently to stimuli. In the heart, the consequences are fatal and may lead to irregular heartbeat. While the sodium potassium concentration normally it's always kept within a tight range. In practice, virtually all patients with hyperkalaemia will have reduced GFR, glomerular filtration rate, and will have renal failure, because the kidney will not be able to excrete potassium and will load into the glomerular filtration rate is very low. Hypoaldosteronism, because the aldosteronism will stimulate sodium reabsorption in the renal tubule at the expense of the potassium and hydrogen. Have metabolic acidosis, and this is the reciprocal relationship between potassium and the hydrogen ion. As the concentration of hydrogen ion increases, so potassium ion inside the cell are displaced from the cell by hydrogen ion bombs in order to maintain electrochemical neutrality. Insulin deficiency, because insulin stimulates cellular uptake of potassium and play a central role in treatment of severe hyperkalemia. Where there is insulin deficiency, hyperkalemia is associated feature. So this figure summarizes hyperkalemia. So the hyperkalemia is mainly got through the digestive system, the intake. Some of the concentration of potassium are lost very few amount in feces. Majorly it's concentrated in the ICF. Most of the potassium is concentrated into the ICF, while very minimum amount is concentrated into the ECF. Some of this potassium is renally excreted. If you want, this figure summarizes how hyperkalemia is associated with acidosis. So you can see that in a normal condition, potassium is retained inside the cell, while in acidosis, the potassium is recruited to the outside, coupled with the recruitment of protons, ions. This will lead to acidosis. This is very severe on heart, because this in figure of the ECG diagram of the heart, the first one is the normal ECG, while in the other one, patient with hyperkalemia will notice that the T wave is peaked and there is a widening of the QRS complex and change of the rhythm of the heart beating. There is as well a condition which is called pseudohypokalemia. Most of it is due to sometimes analytical errors or biological error. It's actually the increase in concentration of potassium due to its movement out of the cell during or after withdrawal of blood from the patient. The cause of this condition, it is the delay in centrifugation, separating plasma serum from the cells or clot, especially if the specimen is chilled. Sometimes there is in vitro hemolysis, an increase in platelets or white cell count. The main difference, between the serum potassium and plasma potassium, in case of hyperkalemia, you can find high serum potassium, both of them are high, or in pseudo, it will show falsely high serum potassium and while plasma potassium is normal. In the reverse pseudohyperkalemia, again falsely high plasma potassium and normal serum potassium. The fourth subtopic is the hypokalaemia. Hypokalaemia may be due to reduced potassium, as the name implies, reduced potassium intake. Much more frequently result from the increased losses or from the redistribution of the potassium inside the cell. As with hyperkalemia, the clinical effect of hypokalaemia are seen in excitable tissue like nerve and muscle. Symptoms include muscle weakness, hyperplexia, and cardiac arrhythmia, irregular heartbeats. In this figure, you can see as a result of hypokalaemia, there is a flattening in the flattening. You'll see more flattening T wave. It's the other way around. A T wave and U waves are flattened in the patient with hypokalaemia. Okay. To summarize the hypokalaemia and how it's involved in alkalosis, you can see in the first figure, in normal condition, in alkalosis, you can see that there is less potassium inside in the blood vessel, accompanied by less protons and as well. So it will increase the alkalosis. This will increase basic ingredients inside the blood. This slides to summarize the main points concerned with hyperkalemia and hypokalaemia, as well as this will summarize hypernatraemia pathophysiology and how affect the AVP control, as well as how this hypernatraemia is controlled by the gastrointestinal or renal fluid losses that have caused sodium depletion. In this summary, will show the clinical assessment and measurement and management, and how it's treated and how the condition is managed. As well, you can see this is a summary of what we have said about the hypernatraemia. As I said before, these summaries are very important. The fifth topic is the intravenous fluid therapy, and it's integral part of clinical practice in his hospital. Each time fluids are prescribed, the following question should be addressed: does this patient need IV fluids? Which fluid should be given? How much fluid should be given? How quickly should fluids be given? And how should the fluid therapy be monitored? Generally, there are three types of fluids: 5% dextrose, 0.9% saline, and either plasma or blood. You can see how these fluids are distributed inside our body fluids. Generally, the dextrose can reach all the body compartment, while the saline only reach the outer two compartments, while the plasma or blood will reach the plasma level and doesn't enter inside the cells. We'll see in this topic how how the relationship between aging and the fluid and electrolyte and acid-base balance. In aging and fluid balance, you can see that decreased body water content reduces dilution of waste product, toxins, and drugs. Because as we age, there is the water content decrease, and this raises the harmful effect of waste product and toxin and drugs because they are not diluted anymore. There is as well reduction in glomerular filtration rate and number of functional neurons. It reduces pH regulation by renal compensation. The ability to concentrate urine declines. More water is lost in urine. There is the insensible perspiration increase because the skin got thinner. The maintaining of fluid balance require higher daily water intake. That's why when we increase with age, we need to drink more water. The reduce in ADH, and there is a reduction in ADH and aldosterone sensitivity. The relation between aging and electrolyte balance, you can see that the muscle mass and skeletal mass decrease, cause net loss in body mineral content. Loss is partially compensated by exercise, and there is elder people must need a dietary mineral supplement. If you look to aging and acid-base balance, there is a reduction in vital capacity, reduces respiratory compensation, increased risk of respiratory acidosis, as well as aggravated by arthritis and emphysema, which alveoli are damaged and shortness of the breath. In next lecture, we'll talk about the urine analysis. Thank you.